Hello everyone. Today we're going to be going over the triple lumen central venous catheter kit that we have here at Reagan. This is a good kit because it comes with the ultrasound probe cover, the saline flushes, as well as the caps. The only thing you need to use this kit to place the central venous catheter is going to be an ultrasound and your sterile gloves. First thing we're going to do is go ahead and open up the kit. It comes in this big plastic container. I like to throw this on the side and keep it at my feet because it's a nice little place to store any trash or things you're not going to use, so it's an easy cleanup for after you're done. So I'm going to place that on the side right now. Then we're going to grab our kit. First thing we're going to do is we're going to open that bad boy up. Comes with a face mask, and it also comes with the bouffant. We're going to open it up. We have some extra sterile drapes if you're going to use those. Also has our gown. We're going to put these sterile drapes off to the side for now. We're going to also put off that sterile gown, and there is our central venous catheter kit. We're going to put our sterile gloves on. Now that we're sterile, we're going to go ahead and open up the kit. Comes with your ChloraPrep as well. Remember, you need to wait at least 60 seconds after applying the ChloraPrep for the ChloraPrep to dry in order for it to be effective. And you want to do it ×2 over the area of your access site. Go ahead and squeeze that to break the glass, shake it a little bit to express the sterilizing solution, and go in big circular movements. Now that that's done, you're ready to begin. We're going to go ahead and open this up. These are the saline flushes. It gives you 3. You really only need 2, about 20 cc's. So we're going to go ahead and open 2 of those up and pull them out. Put that third one off to the side just in case we need it later. Now, this is our sterile drape. It shows you where you want to put the direction of it to make sure that there's a little clear plastic area where the patient's head is so they're not blind while you're doing the procedure. Pull off the adhesive covering. Now what I like to do is I like to fold it so you can really make sure you're going over the right spot that you've identified previously with your ultrasound in a non-sterile fashion, and then ChloraPrep that spot. You're going to put that there, you're going to open it up, and then you're going to pull and have someone pull the bottom part down to fully cover the rest of the patient. So now we're sterile, we're draped, patient has been prepped. We're going to grab our ultrasound probe cover kit that this comes with. It comes with 2 rubber bands. I usually only use 1. We're going to go ahead and put that off to the side so it's easy to access. Now we're going to go ahead and prepare our kit. This is our tegaderm. We're going to go ahead and open that up. Take off that clear piece, and now we have the adhesive side, and we're going to put that off to the side so we can use it when we're ready for it. Throw away that trash. Get rid of all the extra parts that we're not going to use in the kit, like the lidocaine explanations, and there's an extra needle there that we're not really going to use. And we are going to get everything ready. You also don't really need this tubing. I'm not really sure why it's in the kit, but I don't really use it. So you can go ahead and put that off to the side as well. This kit does come with lidocaine, and so you don't need to have extra lidocaine available unless you think you're not going to be able to fully anesthetize with just the 5 cc's that it comes with. We'll pull that out, we'll pop the cap, and we'll get that ready. comes with a little bit of gauze that we can use for a little bit of extra bleeding that we're going to get. We're going to go ahead and prepare our needle driver and our needle. We're going to go ahead and lock that needle in a safe position so we don't have any accidental pokes. And we can go ahead and put that off to the side as well. Now, this is our guide wire. We're going to go ahead and take the cap off of that. And we're going to go ahead and load that tip so that it's ready to feed into the patient's vein through the access that we're using. And I like to put that on top of the drape near the patient so it's easy to grab as soon as you obtain vascular access. Now, there are two ways to obtain vascular access in this kit. There is this syringe with a needle guard on it. First thing you're going to want to do is go ahead and break the seal on that syringe so you don't have to do that while you're doing the procedure and possibly come out of the vessel. The nice thing about this syringe is that there is an internal guide for the wire. We're also going to break the seal on the needle itself connecting to the syringe, so if we want to put the guide wire directly in there, we also don't have to mess around and possibly come out of the vessel. And so the two ways to use this for the guide wire is to put the guide wire directly into that needle. You can also put the guide wire in that blue top part right there, that hole, and that'll feed directly through the syringe into the needle and into the patient. I prefer that because it's a little bit easier and it's one less step to take the syringe off. We're going to go ahead and place that in the foam to make sure that sharp is protected. We're also going to get our other syringes that we have. They give you one for the saline and one for the lidocaine. And we're going to go ahead and take the caps off those. And I like to use the 5 cc syringe for the lidocaine because the lidocaine bottle is 5 cc. So we're going to go ahead and draw up 5 cc of lidocaine. We're going to make sure that we're using the 22 gauge or 23 gauge that they give you. And we're going to go ahead and make sure we protect that sharp as well in the foam. Now we're ready to take a look at our central venous catheter. It comes with 3 preloaded caps. You don't use these caps, they're just part of the kit. You can go ahead and toss those little blue caps. First thing we need to do is go ahead and clear out that little bucket over there because that's where we're going to drop our saline. And we're going to go ahead and put about 20 cc's of saline into that container so we can use it for the procedure and to flush our line. You only need about a half cc of saline to flush the line, and you can add on the caps to the white and the blue part of the central venous lumen catheter head. So we're going to preload our cap on, drop some saline. The wire will come out of this brown port right here, so we're not going to put a cap on that, but we will flush it, and then we're going to go ahead and kink it with that little blue lock to make sure that we don't introduce any air into that line. So you just put the cap on, and then you flush about a half cc until you start to see water, saline come out, Then you take that off and you grab your next cap. And you do the same thing with the blue port right there. Make sure that you see that saline come out the end. That's perfect. And then we won't put a cap again on this brown port because that's where the wire is going to come out, but we will go ahead and flush it. And then we're going to go ahead and lock that so we don't introduce any air. Now your central venous catheter is flushed and loaded with the caps, as well as locked on the brown port. And I like to go ahead and place that on the drape as well, so it is also easy to access and grab once we're ready to use it next to the guide wire. Now we're going to get everything else ready. This is a angiocath that also comes in the kit. Some people like to use this, especially if the patient is volume down or dehydrated and the vessel is a little flat. You can just poke in and then advance the angiocath right over the needle and make sure that you're in the vessel, and then advance the guide wire through the angiocath. That's an alternative way of doing it. I prefer the blue syringe most of the time, but that is an option that you have, the angiocath. So we'll put that off to the side since we're not going to use it for this video, but just know that that is an option. Now we'll get everything else ready. This is our dilator. I like just to have everything loaded and easy to access, easy to grab. This is our scalpel. I don't like to extend the scalpel yet because I don't want an extra sharp on the field, but we'll go ahead and get those ready and easy to grab when we need them. This is a lock that you can use to put over the central venous catheter if you have a patient that is a little bit shorter, because a lot of times we end up putting these central venous catheters too deep into the right ventricle, and you can actually measure the central venous catheter against the patient's body and kind of estimate where you want it to be, which is in the superior vena cava, and usually about 15 to 20 centimeters is how deep you want to go depending on the patient's height, and it gives you markers for that 15, and if you hub it, it's about 20. So you just want to make sure you're not putting it in too deep on the patient. And there are those markings, those centimeter markings, so you can know how far that catheter is in the patient's body. And so if the patient is shorter and you don't want to sew the central venous catheter to the patient's ear, you can go ahead and lock that in right after it comes out of the skin, and then suture that part of the thing to secure the central venous catheter instead of the other part. We'll put that off to the side for now. This is our extra cap. We're going to put that off to the side. We'll load that onto the central venous catheter after we've removed the guide wire. Let's go over our probe cover. This is the probe cover. That top part is where you're going to grab the ultrasound probe. This one is easy to kind of figure out which way's up and down. You just open up the part that doesn't have the thing sticking out of it and put your hand in there. And you can go ahead and grab your ultrasound gel. Put a little bit in your hand there, and then you can go ahead and have someone hand you the ultrasound probe or grab it, and then pull down the ultrasound probe cover over the ultrasound, and then you're going to want to go ahead and secure that with one of the rubber bands. And I usually like to lay the ultrasound over the patient's body in the drape so it's also easy to access when you need it. We'll put that off to the side for now as well. Okay, I think we are about ready to go ahead and start the procedure. One of the most important things for this procedure is making sure you anesthetize the patient properly once you have your lidocaine drawn up. Just remember that you want to make a skin wheel, and that you also want to go ahead and use your ultrasound and identify where the internal jugular vein or the femoral vein are, and make sure that you're anesthetizing not just the superficial part of the dermis, but also going into the subdermis and the muscle or fascial layers below that, just above the vessel, so you get adequate anesthesia. Please remember that lidocaine takes approximately 5 minutes to kick in. And so once you've administered the lidocaine, you're going to want to hang out for at least 3 or 4 minutes so that the patient is fully anesthetized, and it'll make the procedure easier because the patient won't be kicking and moving while you're poking him with a big needle. And that also gives you a good idea of the direction you're going to go while you're looking at the vessel, and you want to make sure that you're visualizing that needle tip right above the vessel and in those subcutaneous layers, and that you're not in the vessel while you're injecting lidocaine. So now that we've injected the lidocaine, we are going to go ahead and wait 5 minutes or so, and then we're going to go ahead and start the procedure. First thing you're going to do is you're going to grab your syringe preloaded with your big needle. Make sure that the syringe is unlocked. Make sure that the needle part is able to easily separate from the syringe itself. You're going to find the vessel. You're going to go in at a relatively steep angle and get under the skin. Visualize your needle tip, and go ahead and visualize that the needle tip is inside the vessel. I like to walk it in a centimeter or two because you're putting pressure on the skin with the ultrasound probe, and when you release that ultrasound probe, sometimes if you're not all the way in the vessel, then it can pop out. And so I like to walk it in a little bit like you do with an ultrasound guided IV, so that when you remove that pressure with the ultrasound probe, the needle tip also doesn't come out. This is a Seldinger technique that you're going to want to use for this, which I'm sure we're all fairly familiar with. It does take a good bit of practice. Once you're inside the vessel and you're drawing back blood, you're going to go ahead and lock your hand in place. You can either remove the syringe and feed the guide wire in that way, or the way that I prefer to do it is to just leave the syringe on, and then grab your guide wire, which has been loaded already, and feed that guide wire directly into the blue hole at the top of the syringe, and that should feed nicely. Now the guide wire is pretty long. It's like 30 or 40 centimeters. You don't need to use all of it. I think that a lot of times junior learners will go ahead and use all of the guide wire until they essentially see ectopy, which is not always the best, especially if you're placing this on a patient that is prone to ventricular rhythms. And so I'll usually go in about 25-30 centimeters just to make sure that I'm good in that vessel, but not like all the way in the ventricle. Then once the guide wire has been placed, you can go ahead and confirm the placement with your ultrasound, and then you can take off the loading apparatus for the guide wire and make sure that you're always keeping one hand on the guide wire. That's going to be key for the rest of this procedure, is you always want to have at least one hand securing that guide wire at all times. So you can pull the syringe off first, keeping one hand on that guide wire at all times, and then pull that needle off as well, making sure that we have control of that guide wire. Okay, now that we have a guide wire in the patient's vein and we have our guide wire secured, we can go ahead and again double check if you want to with the ultrasound that you're in the appropriate vessel and that you're not in the carotid or the femoral artery. Then you're going to grab your scalpel, extract the blade, and you're going to go ahead and make a skin nick. Now, a lot of times people make too small of a skin nick, and that can be problematic. I like to put my scalpel blade side up against the guide wire and just push down. You need to go down at least a centimeter and a half to get a decent tract and a decent break in the skin so that the Dilator, when you push it down, doesn't kink the wire if you're using too much force and it's trying to go against a skin nick that's not big enough. But now we have a skin nick. Maintaining control of that guide wire to make sure that we don't lose it inside the patient. And there's going to be a little bleeding when you make that skin nick, so just have your gauze ready, and you can hold pressure and hold the wire there at the same time, just so that we don't make a mess. Now you're going to grab your dilator and feed the guide wire on to the dilator. Now this can be hard to maintain control of the guide wire, so I like to loop it a little bit, so you have the one hand that's securing the needle also stabilizing the end of that guide wire, and then feed your guide wire through. And then the key thing for this, for the dilator, you grab that tip of that guide, for the dilator you grab the tip of the guide wire, and you're going to go ahead and apply firm pressure with the dilator in a twisting motion. You don't want to push too hard because again that will kink the guide wire, but just a firm, gentle pressure. And you also don't have to put the dilator all the way. You don't have to hub it. You only have to go in about halfway, 2/3 of the way in. So you're going to go ahead and dilate your tract. And then this is also going to bleed a decent amount when you pull that dilator out, because now there's a tract from the guide wire, from the vein all the way to the skin. And so just have your gauze ready, because that will bleed rather heavily. And now you're ready to load your central venous catheter onto the guide wire. We're going to go ahead and loop that again, just because it's easier to feed that on to the end and maintain control of the guide wire at all times. And again, that guide wire is going to come out of that middle port, that short one, the brown one. And you just feed it until you see it come out in that clear tubing, and make sure that you're always having one hand on that guide wire. And as you can see, it's coming out there, and then it's going to go ahead and hit that lock that we had earlier to prevent the saline from leaking out. You can just use one hand to go ahead and unlock that, just like that, between your first and third finger, and use your thumb to go ahead and lock it. And then you can advance the catheter into the patient's skin a little bit, feed it. And then once the guide wire is coming out of that top part, go ahead and grab that so that always one hand is on that part. And then go ahead and apply the same kind of gentle pressure we did with the dilator to just feed that central venous catheter into the patient's vein. Again, remember how far you intended to go. Oftentimes you don't need to hub it, and so only go far enough so that you're inside the superior vena cava, or in the superior vena cava, and you're not hanging out in that ventricle. And then once you're in that appropriate length, you can pull the guide wire out. And you should have a little bit of blood start to return from that middle port. Now, a really key thing here is you're going to want to hold up that guide wire and show it to whoever else in the room, the nurse, the resident, the medical student, and just have them confirm that you've pulled out the guide wire, because we have had several guide wires that have been left inside the patient, and that is a fairly serious complication. Okay, so now we are going to grab our syringe, put a little bit more saline in there, put our third cap on. You can actually preload this after you've done the other two caps, so you don't have to do that extra step with the central venous catheter in the patient. Just makes things a little bit easier. And you're going to go ahead and draw back a little bit, make sure it's pulling back appropriately and easily, and then you can use about 0.5 cc to make sure you flush as well. But you don't have to dump the entire syringe in and refill it every time. Just enough to see that there's good blood flow. And once you've done that and that cap is secured, you're going to go ahead and confirm that the other two ports are pulling easily and flushing. And so you can just use that saline loaded syringe and pull back a little bit till you see blood return in that clear part of the tubing, and then go ahead and flush it again. You can do the same thing with the blue port. Pull back, So you see blood come in that clear tubing and then flush to make sure that each port is working appropriately. And now you have a central venous catheter that's been placed in the patient, and it is time to secure it. Assuming this patient is a little bit shorter, we're going to go ahead and use the locking system where you put the white part on first, right where the catheter is coming out of the skin, and then lock it in place with that blue harder plastic piece, and then you can suture that directly into the patient's skin. If you have any extra lidocaine, this is a good time to see if you can anesthetize that area a little bit, because it is a big needle that you're going to be using. But if the patient is sedated or paralyzed or intubated, you oftentimes don't have to do that. Just 2 simple interrupted sutures on either side. I like to go through the skin first, and you can even drop a suture there and then put it through the little hole on the side there and then tie another one. Or you can just do a single simple interrupted directly through there. And then do that on both sides. Make sure you lock your needle to control your sharps. And now we have a appropriately secured and placed central venous catheter, and it's time to apply that Tegaderm. We've already taken the clear part off. That little piece of gel there is antimicrobial, and you're going to want to place that right over the area where the central venous catheter comes out of the skin, and then you can pull off the extra piece of paper right there, and then use that bigger one to go ahead and just make sure that you have a really sterile and secure area, and you're going to put it right there. And now it is secured, it's appropriately placed, and we have a sterile dressing on top of it. And you're going to want to go ahead and make sure that you look at that x-ray and make sure that it's appropriately placed. But if you did everything correctly, you should be in the right spot. And once you have your x-ray back to confirm, you should be ready to use it for meds.